Good afternoon. I want to welcome all of you to this week's session of Happy Hour. This is kind of the third unit in our Dermpath Basics, and the emphasis on this particular session, as I'm sure you know from looking at the slide deck, is knowledge of regional anatomy. And you might ask your question, well, why would it be important to be able to correctly identify anatomic sites? Well, actually, there are a number of good reasons. One, as you know, certain conditions have a predilection for certain anatomic locations and certain age groups. And if you can look at the slide and identify the rough anatomic region, that's going to help you narrow your differentials. And that's particularly useful when you're taking an examination, let's say your Dermpath core, or even the Dermpath, applied exam at the end of the residency. The second reason is that it's important is really much more pragmatic. There's going to come a time, if it hasn't happened to you already, when in clinic, you're going to inadvertently put two specimens from the patient in the same bottle, or the MA is going to hand you specimen bottle B, and you're going to put specimen A in there, and she's going to hand you specimen bottle A, and you're going to put B in there. So I can tell you it's going to happen. I practiced clinical derm for a number of years myself, and I've made those mistakes. And if you have a decent understanding of regional anatomy, provided that the sites were taken from different areas, it can really help get you out of a pickle. So those are all good reasons to focus and drill down on correct identification of anatomic sites. So I gave you an answer bank here of various locations. And we'll go ahead and just look at the slides, and then I'll tell you where each comes from and what the criterion that I used for that was. Okay, so let me flip this particular slide. We're not going to, the focus here is not going to be so much on entities. We have a bisected punch biopsy here, and this particular specimen was from the face. We know this is from the face because the epidermis is relatively thin. We do have a little bit of solar elastosis within the papillary dermis. And most importantly, we have a high concentration of follicular and sebaceous units within the dermis. And note these hair follicles are a little miniaturized, vellus, and they're not embedded in the fat. If we had these same changes, as we'll see in a subsequent slide, and the hair follicles were larger and embedded in the fat, then we would be dealing, in particular, if it was from the face, from the bearded area, or of a male, or from the scalp. So this is facial skin. Hopefully the second slide was a little bit easier. This was a biopsy specimen from the ear. One can see the configuration of the lesion resembles that of the helix. We have a large fragment of cartilage there. And then we've got quite a bit of fibrofatty tissue within the specimen in the central core. And on ear, one can see frequently an increased number of vellus hair follicles, these small miniaturized folliculo-sebaceous units. This is very characteristic of the ear. One can get a similar concentration of these vellus hair follicles near the eyelid too, and near the cheek, but obviously we've got cartilage here, and the overall configuration is most suggestive of ear. I neglected to say at the start too, if you have any questions, please feel free to email them to education@sagisdx.com, or you can contact me directly, tdavis@sagisdx.com. And my phone number is 210-416-4815. Don't mind getting texts either. Our next biopsy, this particular specimen was from the axilla. And the key features here that are indicative of an axillary site are somewhat subtle. Down at the base of the specimen, actually somewhat separated, there were enlarged apocrine glands. And the key here is that this is apocrine-rich skin. Apocrine glands tend to be have a bigger lumina than eccrine glands, and of course one sees decapitation secretion along the lumina. This could also be genital skin. The important thing is it's from an apocrine-rich area, and so axilla was the correct choice here. Moving on to our next case, slide number 4. This actually was a punch biopsy from the back, but really one cannot distinguish trunk or proximal extremity and from one another. So you really, looking at a biopsy, you can't tell whether it's from the chest, the back, the proximal upper arm, or the proximal lower leg. All those sites are characterized by a very thick dermis and a relatively low concentration of follicular and sebaceous glands. Typically, unless one's very close to the head or neck, there's not quite as much solar elastosis in biopsies from this site as well. And, if you ever have any doubt about where a site is from, or someone says, take a pick, trunk or proximal extremity, unless you're obviously from a different site, is a good choice because, again, it's obviously the largest piece of real estate that we tend to see or deal with. Okay, moving on to slide number 5. This was a biopsy. I'm going to flip the slide here, actually from genital skin. There weren't a lot of apocrine glands, but the key to recognizing this as genital skin was the abundance of smooth muscle fibers here. This was actually from the scrotum, and one can see several smooth muscle endels in the dermis, which is very characteristic for genital skin. Sometimes you will see apocrine glands as well, and frequently the skin is the epidermis is a little papillated as well. So genital skin. Okay, 1, 2, 3, 4, 5. Moving on to slide number 6. This was a biopsy from oral mucosa. We have a dome-shaped papule. This was a bite fibroma or oral fibroma. The epidermis is somewhat acanthotic, and the key to recognizing this as an oral biopsy, or mucosal biopsy rather, is the fact that there's a perikeratotic stratum corneum. This epithelium is keratinizing without interposition of a granular layer. So we've got stratified squamous epithelium. The cells up near the surface of the specimen are a little swollen. Sometimes one will even see glycogen accumulating in mucosal epithelium. There's an absent granular layer and overlying perikeratosis. So very characteristic changes of mucosal epithelium. Moving on to our next case, 1, 2, 3, 7, slide number 7. Slide number 7 was from a volar surface. And in this particular biopsy specimen, note that there's an absence of follicular units in the dermis. We have some eccrine ducts, but no follicular units. And the stratum corneum is markedly thickened by compact orthokeratosis. And when you have a thick stratum corneum and an absence of follicular units, always think about a volar surface. One can see the eccrine ducts emptying directly into the epidermis here, and the intraepidermal portion of the eccrine duct is known as the acrosyringium. These keratinize, as I'm sure you remember, at a lower level in the epidermis than the keratinocytes do, and they produce the cornified cells of the acrosyringium produce these coils that one sees in the thickened stratum corneum of a volar surface. Okay, let's go ahead and move on to slide 8. Slide number 8. This was a biopsy from the scalp. It could also be from the bearded area of a male, or conceivably even from other areas in which one gets terminal hair follicles. We have these large follicles. One can see that they're embedded in the fat. The inferior portion of the hair follicles are in the fat. These two hair follicles are going into catagen, telogen. And again, notice we have a high concentration of follicular and sebaceous elements. So this is very characteristic of scalp, skin, or beard. Slide number 11 was a biopsy from distal extremity. Now, for those of you who've been doing dermatology for a while, you know that when you punch distal extremity, you frequently get fat in the punch biopsy specimen, as opposed to the trunk. Usually when we do a biopsy from the trunk, the back, we don't get much fat. But if in a punch biopsy specimen, you see about half the specimen or a third at the inferior portion containing fat, that's a real useful clue to the diagnosis of distal extremity. Frequently in distal extremity punches too, you will see large vessels at the dermal subcutaneous junction. And again, one has a relative paucity. One sees a relative paucity of follicular and sebaceous elements. In terms of distinguishing distal upper extremity from distal lower extremity, that can be a little bit difficult. One tends to see more pronounced solar elastosis in the dermis of distal upper extremity. And then this happened to be from the leg, the lower leg. And sometimes in vessels from the lower legs, one can see somewhat thick-walled vessels. The postcapillary venules tend to have a little bit thicker walls than one sees in biopsies from the arm. And moving on to slide 10, our last slide. This was a beautiful example of normal eyelid skin. This was actually from a blepharoplasty. One can see eyelid skin, cutaneous eyelid skin is actually pretty thin. We have an increased number of follicular units. One can see abundant skeletal muscle in the dermis. Of course, skeletal muscle tends to be present in the dermis of the face, these representing the muscles of mimetic expression. Also in the neck, the platysma will insert in the dermis. We can see these enlarged sebaceous glands, the Zeiss and Moll's glands, and we can see transition here from the stratified squamous epithelium, the cutaneous eyelid, to the conjunctival epithelium here. And you'll notice we move from stratified squamous to stratified squamous, but within the stratified squamous conjunctival epithelium, one begins to see some goblet cells. So that was kind of our quick run through normal cutaneous anatomy. Just wanted to give you some slides that you could practice on. Hopefully you have found the first series of Dermpath Essential talks helpful. Please feel free to share them with your colleagues. And then next week, we're going to be doing 9 unknowns from the full spectrum of dermatopathology, some inflammatory conditions, some neoplastic conditions, and even some depositional disorders. And hopefully it'll provide you an opportunity to practice and apply some of the basic dermpath skills that we've been discussing. I throw in a few challenging cases as well to keep it entertaining for the upper level residents. But again, thank you for joining. If you have any questions at all, please feel free to reach out and contact me. And hope you guys have a great evening. Thank you.